Good morning, good afternoon, and good evening to all the speakers, chairs, and the wonderful audiences in different parts of the world. Welcome to the ACNS webinars. The speaker for the first section of today is our honorable guest from Italy, Dr. Sabino Luci. Professor Sabino Luci is an associate professor of neurosurgery at the University of Pavia in Italy, where he also serves as the vice chair of the neurosurgery residency training program and a board member of the PhD program in experimental medicine. In addition, he is a consultant neurosurgeon at the Fondazione IRCCS Policino San Matteo in Pavia, Italy, and is also a GMC certified neurosurgeon in the UK. His main areas of clinical and research interests include cerebral aneurysms, cerebral revascularization techniques, vascular malformations, as well as brain and skull-base tumor. Professor Luci is actively involved in several international neurosurgical societies and serves as a faculty for practice neurosurgical hands-on courses around the world. A highly sought-after speaker, he has presented at numerous international congresses and offered a wide range of scientific publications, including peer-reviewed articles, books, and book chapters focusing on neurovascular and skull-base surgery. He also contributes to top-ranked neurosurgical journals as a member of their editorial and review boards. We're extremely honored to have him today at our webinars, and today he will be talking about the intraoperative augmented reality fiber tractography, pitfalls and tenets. The speaker for the second session of today is our honorable guest from China, Professor Xin Zheng. Professor Zheng is an associate chief neurosurgeon specialized in skull-base surgery and the vice chairman of the Neurosurgical Youth Committee of Sichuan Medical Doctor Association. He is a member of the Standing Committee of Head and Neck Tumors branch of Sichuan Medical Communication Association and the secretary of the Skull-Base Neurosurgery in Association of Medical Exchanges across the Taiwan Straits since 2019. He has won several awards and honors for his outstanding contributions to neurosurgery. We are extremely honored to have him today at our webinar, and today he will be talking about preservation strategies for Sylvian wings in skull-base dissection. The chair of the first sessions of today's webinar is our honorable guest from Istanbul, Professor Abusa Kung. Professor Abusa is the professor of neurosurgery at Yadip University Hospital. He is also in charge of the famous Yadip Neurosurgical Laboratory. He is the chairman of the Young Neurosurgeons Forum Committee, and he is also a specialist in fiber dissection techniques and complex skull-base approaches. And we're extremely grateful to have him for accepting our invitation to chair the session of Professor Sabino Luci. We are extremely grateful to honor to have him today. The chair for the second session of today is our honorable guest from Japan, Professor Masaru Abiko. Professor Abiko has more than 20 years of experience in neurosurgery. He got his PhD from Hiroshima University in Japan. He's currently the Associate Manager for Emergency Medical Care Center and the Department of Chief Manager in Onichi General Hospital. His clinical interests are focused on the cerebrovascular and skull-base surgery, and he's the expert about the topic of the patterns and the preservation of Sylvian rings in skull-base surgery. We're extremely thankful for him to chair the session of Professor Xin Zheng. So on behalf of the Educational Committee of the ACNS and the President, Professor Yoko Kato, I would like to welcome both the speakers and chairs and the audiences to this online platform of the ACNS webinars. A very warm welcome for our colleagues in China, and we're extremely thankful to Professor Sylvian for broadcasting the webinar on the WeChat channel. And Dr. Liu Wensing from Malaysia is my co-host today, and with that introduction, I would like to hand over this online podium to our first chair, Professor Abusa Kong. Professor Kong, please.
Thanks for your invitation to moderate this session. It is an honor for me. As you know, what method dissection and what method tracks of the brain is very important for neurosurgeons, and also how to do what method dissection, how to learn in neuroanatomical laboratories. Also, Professor Sabino Luzzi performed a lot of white matter dissection in a laboratory, and now he is using this knowledge in operations. And today he will show us how to use this white matter, the anatomy of white matter tracts of the cerebrum. Professor Lizzie, you can start.
Thank you so much. Thank you. Thank you to all of you. And I want to thank you once again for the effort, as I told you, that you pull together every day in keeping high the interest toward, neurosurgery and education, especially for young people. I want to thank you, especially Professor Yoko Kato and Professor Sylvian. And also I want to thank you, Dr. Kuti and Dr. N.G. Ben, for the technical support. And I couldn't be more happy to be introduced by Professor Gungor, and it's an honor for me because I was his fellow in the lab, and we are also very good friends and work together because we share the same philosophy, and our philosophy is to, trust in anatomical dissection, neuroanatomical approach that is the backbone and the basis of every microneurosurgical technique. Thank you once again. The topic today of my lecture is intraoperative augmented reality fiber tractography, pearls and tenets, and I will share with you my humble experience in using this technique, in my recent experience. This is an overview that I want to show you about the, total volume that does exist in the neurosurgical literature about three different topics that are the so-called three branches of the so-called extended reality, namely the virtual reality, augmented reality, and mixed reality. This is just to show you how great is the interest over this topic and how great has been in the last 10 years, the literature volume about especially the extended reality in all its forms. And we also, this is not future, this is already the reality. Why? Because we have some ongoing clinical trials today, and this is the volume of the updated up to July 2024 of the ongoing and already finished clinical trials where the global level of evidence of the using of this technique, especially the augmented reality, that is one of the most, trusted one, and one of the technique where we collected more experience, have reached sometimes class 2 even evidence that is absolutely important. As I told you, when we talk about virtual reality and augmented reality, we have to take in mind that virtual reality, augmented reality, and also mixed reality are different parts of the so-called extended reality. Especially I want to focus on augmented reality. The augmented reality is a technique that involves the superimposition of 3D computer-generated virtual objects. That means that when I take a look, when I see through the eyepiece of the microscope, I see directly the augmented reality picture that, and my augmented reality picture are the white matter fiber bundles, as I will show you very soon. Again, when we talk about augmented reality in brain tumor surgery, we have some expectation of introducing and implementing this technique in brain tumor surgery. What are our expectations, and what is the role today of the augmented reality in brain tumor neurosurgery? We have some goals. The first goals that we can reach with implementing augmented reality is to increase the awareness about the spatial orientation of the fiber tracts within the brain, and especially also in cavernoma surgery. It is very close to glioma surgery because we share the same technical rules in most of the cases. We can also use this technique in differentiation tumor tissue from healthy brain tissue. When we talk about the augmented reality in brain tumor surgery, we have different examples that I'm going to show you, like ICG, like fluorescein, like 5LA, and so on. And also, we like to check the patency of the neighboring vessel when we perform a brain tumor surgery in terms of video angiography. Today, we have focused more attention with the confocal laser endomicroscopy, that is an in vivo technique that is fluorescein-guided brain tumor surgery that brings the brain tumor surgery at a cellular resolution. And then we can also have the photodynamic and sonodynamic therapies that are the most recent technique that appeared in the neurosurgical literature that are collecting more and more interest. But all of these aspects are different parts of the potential implication of the implementation of the augmented reality in brain tumor neurosurgery. There are no doubts that, the more tumor we remove, the greater is the outcome for the patient in terms of overall survival and also progression-free survival. This is the cumulative literature review about the impact of the extent of resection of gliomas, low-grade and also high-grade gliomas. And we can also have the constant balance that we should apply between the extent of resection, the quality of life of this patient. And this technique has a rationale behind, and the rationale is to perform the so-called maximal safe anatomical resection, but safe for the patient. So it means that this target aims and strives at keeping high the quality of life of the patient. And also, now we can, talk about the true implementation and the implication of the augmented reality diffusion tensor imaging in surgery. We have three different aspects where we can use augmented reality in brain tumor surgery. The first one is the planning, the second one is the execution, and the third one is the postoperative assessment of residual connectivity. About the planning, don't forget never that decisions in surgery, and especially in neurosurgery, are a critical part of the successful of the surgery. And this is the statement of Robert Salerin that already highlighted many years ago this concept. And this is what we can do today, introducing the deep TI fiber tracking and volumetric tumor outlining in our surgical planning. Sometimes, as I used to say to my young colleagues and my residents in the hospital, I used to spend sometimes 1 day, 2 days just for planning of what I will do the day after in the OR, because every approach should be tailored on that kind of pathology, on that kind of specific patient. About the execution, we can use for sure, and now I will show you some of my cases, we can perfectly use today this kind of technique in brain tumor surgery, starting from the beginning. This is an example where we can use this kind of technique, for example, in planning the craniotomy. Okay, we can do the same with navigation, but through this X-ray vision, we can play according to the position of the lesion and near boring or involving white matter fiber bundle to tailor my craniotomy and to do my best to optimize my surgical approach. Last but far from least, the third most important aspect that comes from the advantage of introducing augmented reality in our clinical practice is the postoperative assessment of anatomical residual connectivity, because we want to perform always a critical appraisal of our surgery, and we want to prove that we were really minimal invasive and conservatives in terms of surgery. And I want to stress a concept here that minimal invasiveness of each approach lies not for sure in the size of the skin incision, as we always use it to say in our group with Professor Gungor also. We don't like to refer to minimal invasiveness as the size of bony craniotomy, but the minimal invasiveness lies totally 100% in the respect of the anatomy and the neuroanatomy, because our anatomical approach, we are firmly convinced that an anatomical approach to every kind of lesion inside the brain is critical and is mandatory. That's the reason why we have to hold a robust and perfect knowledge of the anatomy before to deal with this lesion. But now, after the implementation and after starting to introduce this technique in my daily practice, my question was at the beginning of this story, can augmented reality take some true and substantial advantages in increasing what we called, as I told you, the maximal safe extent of resection of brain tumors? So that's the reason why we started to implement this technique. But before to answer to this question, I want to show you some cases. This is the operative room setup that is critical for a perfect surgical workflow that we have should have in the operative room for what we call augmented reality assisted surgery. Here you see some heads-up display, and this is we usually perform the sort of updated navigation here, not real time because we didn't focus on ultrasound here, but updated and constantly updated navigation here. Heads-up display are important to the people that follow the surgery, but as I will show you, we can see the picture and the images directly into the eyepiece of the microscope. And this is what I told you. This is a critical part of, planning of this lesion. This is a tumor that is very close to the corticospinal tract. When we take a look to these tumors, we realize that this tumor lies at the level of the postcentral gyrus. And this is a postcentral gyrus high-grade glioma here in a 43-year-old patient suffering from left arm numbness. And this is the, preoperative workup that we performed in this patient. And this is also the preoperative study, as I told you. It's critical here to realize that we are very close to the corticospinal tract, but mainly the corticospinal tract, 90% of the white matter fiber bundle here are just in front of the central sulcus, just in front as expected of the postcentral gyrus. So it's critical here, good planning. Also, in terms of patient positioning, we like to, maintain as critical venous outflow from the brain. And this is the view that I had at that time directly into the eyepiece of the microscope. This is what the surgeon sees. This is a sort of X-ray vision. Here we can see the red shape color, and the red shape color is the countering of the tumor here. And here we can appreciate the central sulcus with the central sulcal vein, and the postcentral sulcus as the postcentral sulcal vein here, and the corticospinal tract just in front of them. As I told you, these are different forms of augmented reality fused together, ICG and also fluorescein, according to which we can detailingly study, the venous outflow and the pattern of venous outflow. And the most critical bundle here that we can add the image, and it's obviously the corticospinal tract. And after, another important technical aspect is that adjusting the focus here and going deeper and deeper, we can follow also at the level of the subcortical part, the corticospinal tract. Here, we always, in every kind of glioma, I like to perform according to what we learned to Professor Yashagil, transsulcan, transcisternal approach always, and I always to find the nearest and safest sulcus here. We are at the level of the postcentral sulcus here, where subcortical, I identified the boundary of the tumor here, trying to do my best to preserve the bridging vein here, especially the central and postcentral vein. This is critical aspect of surgery, and this is the surgical field at the end of surgery. As I told you, I always like to perform at the end of surgery the ICG to check the patency of the central sulcus vein and the postcentral sulcus vein and all the bridging veins, because we are on the right side here, very close to the superior sagittal sinus that was exposed. And this is a comparison in terms of white light, ICG, and different form augmented reality. And this is the post-op DTI showing residual anatomical integrity of the corticospinal tract after surgery. This DTI is performed for a critical appraisal of our job 1 month after surgery, and this is the patient a few days after surgery, as I told you. And this is once again a comparison, as I told you, between the white light, intraoperative ICG, yellow tracer, and DTI fiber-based tractography, and these are the main steps of surgery. Someone can argue that this technique is good for superficial lesion, but not for, deep-seated lesion. This is totally wrong, and this is the proof. I use this technique also in so-called deep-seated lesion. Here, this is a case of insular high-grade glioma that I want to share with you. This is a male patient, 63 years old, new onset sleep-related hypermotor epilepsy. I want to stress for young people that the main critical aspect of surgery here is a compulsive preservation of the insular vascular supply that come always from, striatal system, especially from medial and lateral lenticulostriate arteries here. And this is what we learned from Professor Valavanis, that we have the so-called intratelencephalic arterial voltage shed zone here, where we can, trace the limit between the striatal and extrastriatal or midcerebral artery if we talk about, the insula concept vascularization. And this is the case, 63 years old, female suffering from progressive decline in learning, memory, new onset sleep-related hypermotor epilepsy. This is a complex tumor as usual because, every kind of, as we see here, insular tumors are deep-seated. So as I told you, it's critical here to do our best to preserve, the vascular supply of insula here. And we see here that it's critical also to trace and to map, as I did in the augmented reality DTI, the fronto-occipital fasciculum and the deeper part, also the corticospinal tract. And this is a drawing showing the tumor growing pattern here. These tumors are always external to the putamen and medial to the claustrum. So the space where this tumor arouses and usually grows is the space of the external capsule here. So we have to do our best to preserve the putamen, the vascularization of the so-called central cord. That is a concept that came with Professor Roton. And here I show you my planning in surgery. Another important aspect that I want to stress is that in my philosophy there is no need to perform any kind of opercular approach for insular tumors. I always use a Sylvian approach here because we don't need to damage the uninvolved cortical, cortical bundle and of telencephalum also in the neocortex here. And these are the main steps of surgery with the huge, obviously, because we want to expose also the posterior ramus and of the Sylvian fissure here. I like to perform the opening of the carotid cistern in a huge Sylvian transcisternal approach. This is one of the most anatomical surgery that we usually put in practice here. And for young surgeons, this is the view that we always have to face with when we deal with insular tumor and with Sylvian, pterional Sylvian approach. This is a conventional pterional Sylvian approach. This is, opening of the Liliequist membrane. Why? All of this wide exposure. Because we want it, because it is a huge tumor, so we want to expose all the insular surface to be sure about the borders of the tumor here. We want to reach the anterior, superior and inferior limiting sulcus of the insula here. To do this, I like to, perform a generous CSF withdrawal, as I did here, opening the Liliequist membrane. And, this is just for CSF withdrawal here. This is A1, contralateral A1, anterior communicating artery, ICA bifurcation, and this uncus temporal, the most anterior part of the temporomesial cortex here, the third cranial nerve. And here, all this aspect, this is just the first step of surgery, and this is the exposure, because this is exposure surgery. Then I came back here, just opening at the level of the triangular part of at the level of the pars triangularis, the Sylvian fissure here. This is a wide split of the Sylvian fissure. This is the exposure of the most anterior part and the anterior limiting sulcus and the lumen insula also of the Sylvian fissure. I just recognize the most medial part of the lenticulostriate artery here. And this is the full exposure of the peri-insular sulcus here, because I repeat, I want to be sure about limits of my, tumor exeresis here when I perform a Sylvian approach. This is, as I repeat, I use different form of augmented reality, ICG also, and fluorescein. We can, as we learn from Professor Yashagi once again, it is absolutely safe to coagulate the collateral vessel coming from the MC8 and going to the insular cortex here before to proceed to this tumor, but we have to compulsive respect to lenticulostriate arteries here. I identify and I remove, with CUSA here, that is very useful, the tumor at the level of the, subcortical surface of the insula until to reach and to recognize, you know, the putamen that is the lateral part of my exposure. And this is what we can follow on the heads-up display of the screen here. I used some anatomical landmark and orientation that are lenticulostriate arteries here before to, you know, recognize the putamen that is most external surface. And this is the, I didn't use any spatula here, as you see, because when you perform a generous CSF withdrawal, you don't need to use spatula. I always check the flow, you know, from the functional and hemodynamic point of view. And this is the PSI-CG surgical field. Everything is okay. And now I can go home. And I perform this kind of surgery and the constant DTI check where I knew where the front occipital fasciculus was along to the most deepest part of the corticospinal tract. And this is the patient a few days after surgery, no deficits here. And here I reported also, you know, DTI that was performed 1 month after surgery as usual here. This is another case that this is a precuneal, you know, this is one of the first cases where that I performed with the augmented reality. This is the precuneus high-grade gliomas, glioblastoma here. Once again, don't need here to go transcortical. For sure, this is the perfect case for posterior interhemispheric approach. And these are the main steps of surgery here, as I show you here. This is the exposure, and the patient was put in a lateral prone position here. I started to perform a generous, you know, CSF withdrawal at the level of the quadrigeminal cyst, and then I identified the pareto-occipital sulcus as recently described by Professor Ture and Professor Gungor group from Yeditepe. This is the route of choice for this kind of tumor. Pareto-occipital, you know, fissure is safe and is perfect to reach this precuneal lesion, even at the level, even those lesions involving the so-called centrum semiovale here. And the neocortex here was just transgressed at the level of the transsulcal and transcisternal approach. And this is, you know, the visualization in terms of DTI also the occipital, the geniculocalcarine fiber bundles here. I just work in between the pareto-occipital vein and the cuneal and the lingual gyrus here and the geniculocalcarine, you know, fissure here. And this is the postoperative MRI performed a few days after surgery, showing as I just opened the pareto-occipital sulcus here to remove this total precuneus tumors. And this is another example of how augmented reality was critical for me during surgery to increase the spatial awareness of my orientation here. And this is the post-op visual field test, and this is the patient a few weeks after surgery. We critically reappraised, you know, we critically analyzed the overall results of the supratentorial tumor where we use this technique. And we were among the first group in 2021 to publish one of the first series about implementation of this kind of technique, so intraoperative augmented reality in the surgical management of supratentorial high-grade glioma. And when we, these are the, you know, this was the study, and from the technical point of view, we used these parameters of acquisition in terms of DTI, and also, you know, we used this kind of technique in terms of tracer. And the critical step of the surgical workflow were the asleep craniotomy. All these cases were done in asleep craniotomy. CT-based optical tracking registration, augmented reality high definition fiber tractography image always injected into the microscope eyepiece. And we should, and an important trick that I want to stress that, you know, it's critical to avoid any crowding of the fibers within the surgical field, because otherwise these fibers can hide, you know, the visualization of the surgery of the critical and the noble neurovascular structure here. And another important aspect is that I performed a brain shift correction that is, you know, is possible thanks to a finite element model-based elastic fusion that I use with my navigation protocol. We compared at the first time 54 patients of the study group and 63 patients of the control group. And I use this kind of technique practically in every kind of tumor involving the frontal, central, parietal, temporal, limbic, and paralimbic, and also occipital. And this is an overview of the different gliomas that I operated in terms of pathology. What was very, very important that we found from the critical appraisal of this technique, we found that the postoperative nanoscore, so practically speaking, the overall neurological outcome was better when we implemented this technique in our patient than in the control group, probably because of the, I repeat, better orientation, three-dimensional orientation of the awareness of the corticospinal tract, and also the extent of resection intended as a group between, as the sum between the gross total resection and near total resection was better in the study group than in the control group. We also found some advantage in terms of progression-free survival of this patient. The progression-free survival was good, probably because the extent of resection was higher in the study group than in the control group. But for sure, this technique is not. This technique has nothing to do with the natural history of this pathology that is very dismal, unfortunately. So overall survival was not affected by this kind of technique. More recently, we focused especially on some specific region. And among this region, we have the especially primary M1 area, so primary M1 tumors, so namely those tumors affecting the motor strip. This was my strategy. This was my strategy in terms of approach that I used, according to the different growth of pattern of M1 tumors. And when the tumors here, I recently published this article in JNS in 2024, when the tumors arouse at the level of the precentral gyrus and primary motor area, we can have three different pattern of growth. The first pattern is a pattern according to which we can have posteriorly displace the corticospinal tract. The second one is a split corticospinal tract. And the third one, when the corticospinal tract can be anteriorly displaced. For sure, my approach is totally different, and I choose this kind of approach based usually 100% on preoperative planning. Why? Because in the first case, I use always a transprecentral sulcus approach to decrease the likelihood of jeopardize and to cause damages to the main bundle of the corticospinal tract. When the corticospinal tract is anteriorly displaced, I can use as similar to the case that I show you as a transpostcentral sulcus approach. And in those cases where the corticospinal tract was split in two halves, one anterior and one posterior, it's more rational to use a direct transgyral approach that should be carried out as at the beginning from the precentral gyrus at precentral sulcus, as I will show you. This is a case, this is a small tumor. This is a small tumor, but challenging tumor because this tumor is a pure primary motor strip tumor. These tumors arise at the level of the so-called zone 2 of Marshall. So zone 2 means the zone that corresponds to the hand area, hand arm area. And this is a case that I want to show. This is a female, 65 years old, and with the suffering from right hand and new onset seizure. And usually seizure is the onset in this patient in most of the cases. And this is the preoperative workup showing T1 non-contrast MRI, those relationship between the tumor. This is, I repeat, this is small tumor but challenging tumor. But this tumor is totally confined to the precentral gyrus and primary motor strip here. This is enhancing tumor, so with very high probability, as showed also in the preoperative workup from spectroscopy and perfusion and diffusion. This was high-grade gliomas. As we see here from the 3D reconstruction, the corticospinal tract was split in two halves here. The one was anterior and one was posterior. So according to my approach and according to what I just told you, I prefer to use direct transgyral approach here, entering the precentral sulcus always here before to move at the level of the intratumoral aspect here. And in this case, we need to map and to track with the diffuser tensor augmented reality fiber tractography, not only, the corticospinal tract, obviously that this is the most critical part of the surgery, but I also like to, a map and to track here and to have, in my view, also the horizontal part of the arcuate fasciculus here. This is a picture coming from the blending and fusing all together different form of the cortical of the augmented reality. This is a fluorescein, the tracer of the augmented reality, where we see that the tumor perfectly respect everything is just in front of the precentral sulcus. And we see here that the tumor is totally confined to the primary motor strip here. Even in these cases, when I have to perform a direct transarterial approach, I like to start surgery entering the sulcus here to identify my branches, and then moving and the deepest part at the level of the transcentral, at the level of the gyrus here. And these are the main steps of surgery. I try to do my best to stay in the tumor, as Professor Yashagi taught it to all of us, and try to do minimal invasiveness in performing. This is a constant visualization of the deepest part of the corticospinal tract at the level of the bed of the tumor and the horizontal part of the arcuate fasciculus here. Another important aspect is the fact that it's mandatory to perform, also neuromonitoring in this case, and in this case, transcranial neuromonitoring was done about the primary motor area. And this is the Professor Ture technique. We always like to put a thin lamina of gelatin sponge that is very useful in case of redo surgery on second surgery. This is the post-op DTI performed 1 month after surgery at average, as I told you. And this is the patient a few days after surgery, still before discharging here. We performed in this case exceptionally very early DTI, and we saw here as the corticospinal tract was respected at the level of the surface and the level of the deepest part also. This is another case here. This is another case. This is a small case, but also this case was challenging. This case was a primary motor cortex glioblastoma of the right hemisphere. This is once again the World Cup. And the main step of surgery, the story is the same. We like to, this tumor was, in this case, the corticospinal tract. We realized that the corticospinal tract was just a little bit anterior, so anteriorly displaced and laterally displaced, and these are and medially displaced, sorry. And these are the picture, intraoperative picture. I want to stress once again the fact that this was my view into the surgical microscope here. And in this case, a direct transcortical approach was direct transcortical neuromonitoring in terms of motor mapping was performed. And once again, I went here through the precentral sulcus, and these are the main steps of surgery where I could achieve, thanks also to the intraoperative implementation of the corticospine of the DTI tractography, and with 1 centimeter transsulcal approach, I was able to totally remove this tumor. And this is a post-op DTI 1 month after surgery. We critical reviewed and appraised the overall results of the primary motor area tumor, and we recently, this year, 2024, we recently published the results of the implementation of this technique, especially for a primary motor area tumor. And this is an overview of what we did in the study and the study design. I compared 34, patients harboring a primary motor area tumor. In this case, we included not only primary motor area glioma, but also mets coming from different tumors. And we compared this technique with the standard technique 31 study patient. What we found? We found first results, very important. We found, because we coupled always this technique with neuromonitoring, we found first aspect, a lesser intraoperative seizure rate in terms of intraoperative seizure and after discharge. So it means that when we stimulate this patient with direct cortical stimulation at the level of the cortical subcortical level, probably a better understanding and the orientation about the position of corticospinal tract allowed us to stimulate lesser this patient, and the likelihood of seizure, intraoperative seizure, decrease in this case. That is a further reason why to implement this kind of technique. The second most important aspect was the fact that we had a 3-month postoperative nanoscore that was better in the study group than the control group. I want to stress a concept here. All these tumors in primary motor area for sure will worsen after surgery, and it was my experience. All these patients, because of mechanical stretch and mechanical danger that you can cause and the addictive brain edema that you can have in these cases. But when you respect, thanks to all this technique, the corticospinal tract, you have the opportunity here to have a better 3-month postoperative nanoscore. And so the patient will recover. There's a showy deal also in terms of motor score. Medical Research Council score was better in this patient than in the control group. And this is especially score that we had for primary motor area tumor. Extent of resection was better in this group than in the control groups also, and we were very happy about this technique. And the progression-free survival also was significantly better in the study group than in the control group, in the gliomas and metastasis also. And for sure, as I told you, overall survival of this patient was unaffected by the technique because of the natural history. I'm very close to my conclusion here. I want to stress some technical constraints of the technique. The first one is the fact that this technique provides only structural and anatomical, but no functional information about the white matter fiber bundle here. So that's the reason why we need to integrate this technique with functional mapping techniques. That is a critical point of the planning of surgery. The second most important limitation in the parallax, that is a physical phenomenon that we can have when we use different kind of augmented reality projectors. And the best way and the best trick to limit the effect of the parallax is to use the point long function that allows us for a micrometric adjustment, then macrometric adjustment during our surgery. The third most important data is the fact that we should avoid always the crowding of the fiber tracts, because too many fiber tracts can hide, some neurovascular structures. So we should opt for a modular selection of the white matter fiber tracts involvement, and we can switch on and switch off according to our needs during the surgical workflow, even each white matter bundle here. So the key message of this lecture is the fact that augmented reality fiber tractography technique is safe and effective with our experience in maximizing the extent of resection of supratentorial grade gliomas, and it offers a detailed intraoperative virtual topographic map of the white matter fiber tracts. It allows for a safer surgery in the so-called highly eloquent areas, but I want to show you that all cortex and all the brain is eloquent in our philosophy. It needs to be coupled with brain mapping techniques. And once again, I want to stress the critical aspect how to, in planning and in performing surgery to perform, a perfect knowledge of the anatomy. This is the future, and we will implement it in the future very early, the so-called 7 Tesla MRI, where the quality of the implementation of this kind of technique will be even higher than now. This is ultra sharp DTI, and we could implement in our near future this kind of technique. And I'm already working on a project like this to bring this kind of technique and this kind of quality of visualization direct into my surgical field. And my last slide is about, our philosophy of microneurosurgery. Perfection is probably not attainable, but especially for the young people, if we chase perfection, we can catch excellence. And thank you very much for your attention.
Thank you, Sabino. It was a great lecture. And I think you are the best sample to combine the knowledge of anatomy and also philosophy, our philosophy to protect all cortex, because in our philosophy, all parts of the brain is eloquent. There's no eloquent, no eloquent area in the brain. Because of this, we must protect any part of the brain, and also you combine all new technologies with your knowledge of anatomy, because, as you know, we always face with the surgeons who have a lot of technologies in their hands, but not in a good philosophy. And in these hands, with these technologies, they couldn't perform minimal invasive surgeries to the brain. For example, you showed some cases with precuneus area. In the world, most of the surgeons could prefer the lateral approach to this kind of tumors. But with your philosophy, you can protect all these lateral cortex, the cortex located in the lateral surface with intrahemispheric approach. Because of it is very important to use these technologies with a good philosophy and a good knowledge of anatomy. Thanks for your presentation again. I think there's no questions, but we can ask for any comments from the other
Panelists.
panelists and lecturers.
I'll ask one question to Prof. Lucy is like,
Yeah.
what would you advise how to begin this for a beginner?
For the beginner, you mean?
Yeah.
For the beginning, my first advice is to go to the lab. To go to the lab to study in detail the course and the position and the anatomy of the white matter fiber tracts, okay? Because what I show is nothing different than an enhancing of the normal anatomy. So you should learn before where the front occipital fasciculus is, where is the corticospinal tract, which are the landmarks of the corticospinal. This is what I did in the lab under the guidance of Professor Gungor there when I was fellow in Yeditepe. So my advice is to go to the lab, and Yeditepe is the mecca for me for this kind of technique, and this is the first. After that, you should transfer all this kind of knowledge to your workstation for, the future tensor reconstruction of the different white matter fiber bundles. And then what we have to do is to mix together, because you will be perfectly able to find any fiber tracts according to the landmarks that you have, and to trace that kind of fiber tracts. And this is also the best way to clean every cortex, because when you build the model in terms of DTI, you have all the tracts there, but you have to clean there. You have to select just the tract that you want to emphasize, the front occipital, the arcuate, uncinate, whatever you want. And after that, to do that, you have to know once again the anatomy. That's the trick, okay? So my advice, my humble personal advice for the beginner is to go to the lab to study the anatomy, and then transfer all this information, the working station, and working there with the DTI diffusion tensor, software to reconstruct each kind of a fiber bundle, and then transfer this information and integrate this information in the surgical outflow.
And Professor Lucy, I have a question. Would you use the augmented reality constantly during the resection for the glioma? Because we wanted to see the contour of the tumor all the time during the dissection. But when I also use the augmented reality under microscope, because when I use it, I find that when I open the projection inside of the ocular, the visual quality of the surgical field will instantly drop, because of the inside building of the projection of this augmented reality. Will you use it under a ocular or use exoscope function to do this?
I don't have experience with exoscope. That's the reason why I cannot reply to the question about the exoscope. I don't know what will, what will happen in the future with the exoscope. Theoretically, we could have, not interference with using exoscope, but I don't have experience because I always use the microscope. About the problem that you raised about, I highlighted in different point of my lecture the fact that there are an obvious risk of hindering of your surgical field coming from interfacing between your eyes and the surgical field, the different form of the different shape and the different white matter fiber tracks. But the trick that I use is first to switch on and switch off accordingly, okay? I don't use during all surgery augmented reality. I use it to check where the spine, where the cortical spinal tract, for example, of the other fiber bundle are every 5 minutes, 10 minutes on the critical part of surgery when I'm working very close to that kind of fiber tract, and then switch off to have the, you know, free of the surgical field first. Second trick to decrease the risk of crowding of the cortical or of the you know, surgical field with augmented reality is to opt for a modular selection. So I don't want to show, you know, I don't know, the arcuate fasciculus if I'm working close to the uncinate fasciculus, for example, and vice versa. So it's better to select just one or two, you know, tracks when you are working very close to, and then this is the trick to limit every kind of hindering of noble and critical neurovascular structure. This is my, you know, this is what I can tell you based on my experience.
Okay, thank you.
And let me tell you also that, you know, in the picture that I showed you and also in the video, it was very, you know, I do not believe that neurovascular structure ICA, for example, in the case of that I show you, insular glioma, was totally hindered by, you know, the presence of the superimposition of the color. Why? Because I selected just one, you know, bundle that I was closing very close to. But this is the trick to avoid the crowding.
Yeah, some questions. Actually, it's a very interesting talk. I would like to clarify a few points. The first thing is to start with your surgery. So I saw that the operative settings. So is the size clinical microscope with the brain lab is all you need to conduct this VRO assisted surgery. And then my second question is about when you project it on and off. So will the depth of the surgical field will be adjusted automatically? And my third question is about I saw your case in the M1 and also insular glioma. So you perform it. Do you prefer to perform it with a GA? With a VR assisted or awake craniotomy? Yeah. That's what I...
First question about the equipment. I use it. Yeah, you're totally right. I use it in my experience. You know, Kinevo microscope and a brain lab navigation platform in terms of tensor imaging for tensor imaging reconstruction. But it's not mandatory. You can implement this kind even with different kind of microscope and even with different kind of, you know, surgical navigation platform, because to the best of my knowledge, these software are commercially available also for other companies. First. Second, about, you know, the second question was about, sorry, I forgot. The second question was about
the depth when you operate
the depth of the surgical field. Yeah. This is not true 3D representation. Okay, this is a false 3D. So the accuracy in merging and you know, in fuse in your mind the 3D and the depth of the surgical field and the 3D of the superimposed picture, it's not fully integrated. It's the accuracy is for sure not 100%, but there are, you know, no tools to measure how, you know, is the inaccuracy of this kind of technique. What I can tell you in my experience was that most of the interference with the surgical workflow comes from what I showed you as limitation that is called parallax. Okay, this is a physical phenomenon. So if you decrease the rate of parallax thanks to micro movement of the microscope with For example, Kinivo has the so-called point lock function, but you can use different kind of micro movement, even also with a different kind of microscope. You can decrease several times the amount of this physical phenomenon, and you can optimize the perfect integration in terms of sense of depth and perception integration between the surgical field and the true 3D surgical vision. That's the reason why, in our philosophy, we prefer the microscope, as Professor Gungor told. Why? Because the vision of the microscope is a true 100% 3D vision, okay? But you can take advantage from fusing this 3D vision, reducing the terms, the parallax, and using the point clock function, because this phenomenon is as higher as much as the movement and the shaking of the microscope. The third aspect is about awake craniotomy. I do believe that we don't need awake craniotomy for corticospinal tract tumor. We could use awake craniotomy in some other eloquent tumor, especially for leg with satines, but to be honest, I don't have experience in this sense. But theoretically, this technique could be coupled also with awake craniotomy, because I don't see any limitation in fuse and in the implementation of this technique also in the awake craniotomy. Why? Because in case I use it, I use the MRI based navigation and optical based navigation. I have an updated information, but especially in case if you use ultrasound, you can have real time navigation. I don't have experience, but with ultrasound, real-time navigation is even better. So you could use the same technique even in awake patient. I don't see any limitation in implementing this technique also in awake surgery.
Okay,
thank you for this very interesting and stimulating question and debate. Thank you so much.
Thank you so much. So I think we could move on to our second session with Professor Sinsen, and I'll hand over the platform to you, Professor.
Okay, sorry, I'm late. I'll be the chairing this session. I'm Masaru Abiko from Onomi City in Japan. So probably this part is about the Sylvian vein preservation. So the superficial Sylvian vein lies on the surface of the Sylvian fissure, which usually draining into the dural sinus along the sphenoid wing. They bridge the brain and the dura, and which can obstruct the surgeon's perspective or prevent the brain from retracting. If the superficial Sylvian veins, especially the frontal superficial Sylvian veins, are occasionally sacrificed during the dissection, probably the venous infarction or cerebral edema caused by venous congestion may following and resulting in neurosurgical deficit. So we should endeavor to save the subsuperficial Sylvian vein while reserving a wide enough space within the surgical field for the safe manipulation. So some techniques have been described to preserve these veins, and we'll be able to learn about them from this lecture part. So next speaker is Professor Xin Zhang, and the title of the presentation is preservation strategies for Sylvian vein in skull-base surgery. So please, Professor Xin Zhang, please your lecture, please.
Thank you, Professor Abiko. And first, I want to thank Professor Yoko Kato and Professor Benshi to brought us here to share with the audience an ACNS webinar. And also, I want to thank Dr. Ben and Dr. Raj to the organize. My name is Xin Zhan, and My topic is preservation strategies for Sylvian veins in skull-based surgeries, and I have no disclosure. Well, the Sylvian fissure was firstly described by the Franciscus Sylvius. He's a Dutch physician, anatomist, and scientist. The Sylvian fissure is a highway for us to exit the skull base. But before that, we need to pass the Sylvian veins first, which act as the gatekeepers of the Sylvian fissure. Well, in neurosurgery, we're focused heavily on protecting the internal carotid artery and its branches, as well as the optic nerve and brain tissue. However, the venous protection is also crucial, as impaired venous outflow can lead to edema, venous infection, hemorrhage, seizure, and a neurosurgical deficit. The protection of the Sylvian veins involves two aspects: the Sylvian veins themselves and their drainage, including the sphenoparietal sinus, cavernous sinus, sphenobasal sinus, vein of Labbe, and Rolandic veins, etc. And currently, there are several studies on the classification of Sylvian veins, requiring us to carefully identify and separate the paths based on the different vein types during surgery. Well, the superficial middle cerebral veins exhibit many variations during the embryonic developments. And physiologically, the Sylvian vein has various primary drainage directions, which has superior, anterior, posterior agonist mixed. And in pathological conditions, due to the space-occupying effects of the tumor, there are some regular patterns in the venous drainage of the Sylvian vein. The image shows the venous drainage pattern of the different sides of anterior clinoid mesoderma. It's a great, beautiful article by Kenjo Hata. And I would like to use staging detachment techniques for the preservation of the Sylvian veins. And it needs to be emphasized that the above 5 stages are arranged according to the frequency of use, not in the order of surgery. They can be freely combined and implemented according to the actual surgical needs. The first stage is intravenous dissection. The second stage, main trunk detachment. The third stage, frontal detachment. Fourth stage, temporal detachment. And the fifth stage is sphenoparietal sinus transposition. And for the first stage, intravenous dissection, which is often the first step in the subdural operations, it requires carefully identification of the superficial veins, draining the frontal and temporal lobes. Some lesions located solely within the Sylvian fissure, such as unruptured MC aneurysm, may only require first stage detachment to achieve adequate exposure. The sixth stage involves the detachment of the main trunk draining into the sphenospatial sinus, which has been previously reported as a Denude technique. I want to show the first case is a anterior clinoid meningioma. You see that the tumor is kind of middle size, but the Sylvian veins remain function. So I show the frontal and the temporal choroidal to first debulk the tumor. Then we have room to separate the veins from the tumors. And also, this tumor had a kind of a peripheral edema, so the tumor had a strong adhesion with the arteries and veins. This need meticulously dissection and keep debulking the tumor. And so the preservation of the veins, not from the beginning. I think it's during the process when we have rooms, so we can decompress and preserve those veins and focusing on the deep-seated arteries. And this is the final view. Here we can see the patency of the Sylvian veins. and the patient had unimitable recovery. And this one is a 33-year-old gentleman. I had a recurrent headache for 5 months. It's a Sylvian vein involved AVM. And we can see additionally the AVM is supplied by 1 or 2 lenticular straight arteries here. And for the AVM surgeries, I think the preservation for the venous structure is also crucial. We split the Sylvian fissure to identify the feeding arteries of the lenticular straight arteries. So we have proximal control of the deep blood supply for the venous AVM structures. And then it's a dissection, meticulous dissection in the normal veins and arterialized veins, because the arterialized veins is highly inflow and the tension inside is quite strong, so we need a more precisely dissection here, and we can see some bleeding there. And normally we need a precise coagulation for this kind of bleeding to try our best to preserve the venous structure here before we have taken up all the main feeding arteries. And we do continuous dissection between the arteries and the veins. And we sacrifice the unimportant drainage veins and continues to sharp dissection. And the irrigation is important to have a moisture to see the border of this retinal membrane. It continues to dissect and use the IOM to make sure this is a final feeding artery, not the passing by arteries. And continues to dissect, use sharp dissection between the normal veins and arterialized veins. And this is a deep-seated feeding artery, lenticular artery here. And this is a final drainage. And we have a complete control of these AVMs. And this one is a 62-year-old lady and have very impairment for 6 months. You see the tumor is anterocleidomeningioma, and the tumor had completely encased the left internal cardiac artery, and the patient's left eye is only remain light perception. For this kind of case, because of encasement of the internal cardiac artery, we choose extradural approach with anterior clinoidectomy and optic canal decompression. This is patient position and incision. First, we do extradural anterior clinoidectomy, and then the Sylvian fissure to open with a dynamic retraction. And detach the olfactory tract. And localize the optic nerve here. And open the falciform ligament. The decompressed nerve. Have early decompression. And open the oculomotor system, looking for the hidden part of the tumor. And we're exposing the oculomotor nerve here. And for this case, the oculomotor nerve is completely encased by the tumor here. And then we have a limitation of the retraction of the temporal lobe here. So we use a lateral and medial chordal to debulk in the tumor. And we start to using the sixth stage of detachment of the Sylvian vein to release the main trunk of it. This could give us normally a extra 1 centimeter of space to retract the temporal lobe to more adequately expose the tumor base on the temporal side. Now we have a completely access to the temporal tumor base. So we need to, for this case, we need to work in the different chordal is created by the Sylvian fissure here to have an adequate to deal with the tumor base here in the middle and lateral chordal within this oculomotor nerve. You see the oculomotor nerve is completely encased, strong adhesion. And we have losing a subarachnoid interface between here. And for this part, we can see the arachnoid interface is disappeared, which is previously described by Dr. Professor Al-Mifti for the group 1 choroidal meningioma. Here we have drilled in the posterior clinoid to have a better access to the clival extension of the tumor. And here we lose the interface between the tumor and the cortical artery. So this not going to be the complete resection. We need to leave part of the tumor around the cortical artery. Okay, this is a pituitary stalk here. Contralateral posterior clinoid. And this is intact of retract and the Sylvian vein here. This is a patient. The patient had a transient sternal palsy and recovered 6 months later after surgery. And the pathological investigation confirmed grade 1 meningioma. For the third stage, detaching the frontal superficial and frontal basal Sylvian veins can further gain operational space, but it's often quite limited. And the fourth stage, detaching the temporal veins can provide more lateral exposure, but the step is often time-consuming. I wanted to present this one as a rupture of the MC aneurysm and a paraclinoid aneurysm here. This is we use the superlateral approach. We can see the drainage vein here to this sphenoparietal sinus is quite short, so we have to first detach the main trunk here, and then I open the Sylvian fissure to clip this this rupture case. This is a case I think it's 6 years ago. You see this first clip have some obstruction of the view. For recent days, I may clip the aneurysm later. Now we do the third stage of a frontal detachment of the Sylvian vein to have a better access to the posterior client pecan aneurysm. This have give us a limited access to the communicating segment of the aneurysm. This is ICG. And the fifth stage is interdural dissection, which also called the sphenoparietal sinus transposition. We can peeling the dura of the interlayer to transposate the sphenoparietal sinus to have a more space. But the extradural bleeding sometimes extent can affect the cleanness, the surgical field. And additionally, the preoperative evaluation of the drainage pattern of the Sylvian vein is necessary to avoid the damage of the downstream drainage. And here we can see the sphenobasal type of vein, which can drain inside of the cavern sinus directly or into the foramen ovale. This one is a 62-year-old gentleman and admitted with a progressive left visual impairment for 4 months. And the MRI scan relieved the left paracel lesion with cavern sinus and sphenosinus. And the C6 segment of the ICN branches were displaced by the tumor, while C4, 5 segments were encased. The venous drainage pattern of this patient was from the Sylvian vein to basal vein and to the pterygoid plexus. So intradural dissection for the sphenoparietal sinus transposition and dural preservation of the middle cranial fossa is critical to protect the venous drainage. And because the patient had a visual defect, we need to decompress the optic nerve and oculomotor nerve should also be untethered. And another issue is the tumor had invaded the cavernous sinus, so the 3rd to 6th nerves should also be considered in the pre-op evaluation. And this had taken us to a very important question: how much tumor we could resect. The patient was asymptomatic with a cavernous sinus invasion, guided by the contemporary concepts of management of the intracavernous sinus meningioma. Preservation for the cranial nerve function is a priority of the surgery. Therefore, conservative resection could be performed. The intracavernous dissection can be attempted for the subtumors. And because of cavernous sinus invasion and sphenosinus invasion of the tumor, the extradural anterior clinoidectomy and the optic canal decompression were applied. For the tumor inside of sphenoid sinus, we could get access to the sphenosinus through the plana sphenoidale, or the anterior medial triangle, or the endoscopic endonasal surgery. And the transplanum sphenoidale seems to be the easiest way to do this job. We use watertight dural closure for the reconstruction, and abdominal fat graft, and the frontal periosteal pedicle flap to perform a concrete skull-based reconstruction. This is incision and patient position here. Well, the first step of the is extradural dissection. The meningeal oblate band was transected, and we start the intradural dissection, which mobilized the dura propria from the lateral of the cavernous sinus. Also is a transposition of the sphenoparietal sinus, and the anterior clinoid process was hollowed out. The optic canal was unroofed, then the bony window was made through the plano sphenoidale. You could see the tumor here. The submucous dissection was performed, and tumor inside the sphenoid sinus was delivered. we need to make sure all the mucosa was removed. The hydrogen peroxide and propionyl iodine was applied for the disinfection. Then the sphenosinus was insulated by the cottonoid. I opened the dura, started the interdural dissection. The Sylvian fissure was fully opened with dynamic retraction, and the arachnoid interface was maintained carefully. And the devascularization started from the frontal tumor base. The left ICA and the optic nerve were identified. Before I could have the access to devascularized temporal tumor base, the Sylvian vein should be thoroughly detached from the temporal lobe. This technique could minimize the risk of the interruption of the venous system. And this is also called a stage 4. And I find the use left hand is quite efficient to do this job. Then we can complete the exposure of this temporal tumor base. See the complete free of the Sylvian vein. Let's start to debug the tumor. The MCA and oculomotor nerve identified, and small branches were carefully detached from the tumor. The arachnoid interface was cherished and maintained carefully. Sharp dissection was used to detach the passing by branches. You can see the bifurcation of the ICA. And here's when I was dissecting anterior cerebral artery, the recurrent artery of the humna was accidentally injured. Well, the bleeding was not intense, so I decided to compress the bleeding site and move on to debug the tumor and had for sufficient working space. And I started the revascularization. Well, the adventitia was cleaned, irrigated with endocylinar lumen. The 10-0 protein suture was used to a square knot was made to hold two sides of the wound. I made 2 interrupted stitches to repair the artery. Well, the recurrent artery humna supplied the anterior portion of the basal ganglion region. During the procedure, the patient's tumor evoked potential, motor evoked potential remains the same level as before. And remove the proximal plate. The blood perfused to the distal end, which proved the patency of the artery, so I didn't do the ICG here. And I explored the oculomotor system here to look for some residual tumor here. We always do this procedure during the anterior clinoid meningioma. This is complete of the interdural steps. Well, the roof, because the infiltration dura was resected, so the sphenobasal type of the Sylvian vein, the temporal dura should be preserved to maintain the venous drainage here. And because the tumor was soft, I decided to attempt the resection of the intracamera sinus portion. The optic structure was drilled further to have a complete exposure of the Dolan triangle. The back line of segment of the ICA was identified here. This is the oculomotor nerve. A carefully sharp dissection was made to detach the tumor from the proximal ring here. And because I don't want to make too much manipulation of the nerves, so the tumor in the lateral compartment of the cavernous sinus was left over. You can see the middle wall of the cavernous sinus and carotid siphon here. This final view. And the frontal and temporal cortex were intact. The dura was closed with artificial substitute and watertight fashion. Water was exhausted with warm saline. The propionyl iodine was applied to enhance disinfection. The sphenosinus was packed with abdominal fat graft and frontal periosteal fat pedicle flap to apply to reinforce the skull base reconstruction. Well, this patient, so we have a neurototal resection with this tumor. The patient did not have any infection or leakage. The transient diplopia recovered 1 month later after surgery. And another one is a 61-year-old male. He had a right ptosis and diplopia for 10 years, worsening in 7 months. And this is a quite calcified tumor here. This is the incision and patient position. And we continue to use the transposition of sphenoparietal sinus here. We can feel a very dominant Sylvian vein here. So it could not be sacrificed here for this kind of a tumor. And expose the tumor here. And because I could not see the top of the tumor, so I need to first to decompress all the Sylvian vein. Use sharp dissection. For this tumor, we need to do from stage 1 to stage 5, all the detachment for the Sylvian vein to have a quite adequate exposure of the tumor, because the tumor is a very solid calcified tumor. It's not like a normal meningioma, cannot be retracted. We need to see the top of the tumor, because the tumor had a strong adhesive to the cardiac artery. So we have to do all the dissection, direct vision. This is a dissection, the temporal branch of the Sylvian vein. You see, you may think this small caudal vein was drained inside of the temporal Sylvian vein, but actually it's not. We use high magnification to see the arachnoid interface. So we can finally detach the temporal branches, have adequate exposure of the tumor. So this is quite a calcified tumor here. And remove the enteroclinoid process here and have proximal control. Oh, sorry for that. And you see the tumor had a very strong adhesion to the carotid artery here. And here I have a little laceration of the protruding arteries. I was trying to use the temporal clip to rotate the artery to have a better see the carotid artery have a rupture of this carotid artery. But we have a proximal control. And we find out it's actually a dissection tear of this artery because of a strong adhesion. So we need to repair this carotid artery with sutures. And then we had another tear on the MCA here. So this tumor have quite adhesion, strong adhesion to the adventitia. We're mapping the oculomotor nerve here and expose the camus portion of the tumor. Use drill to debulk tumor here and identify the camus segment of the ICA. And this is ICA here. And this completely the surgery and completely intact of the Sylvian vein. The patient pathological investigation come out meningioma. Have a costal resection. Well, what we just discussed, the mainly focus on the surgical craftsmanship of the venous preservation. But having just the surgeon's manual skill is not enough. Venous preservation is a time-consuming task, especially in surgeries for skull-base tumors. Before starting the tumor resection, a significant amount of time is needed to dissect the veins in the Sylvian fissure, followed by several hours of tumor removal. Therefore, it requires neurosurgeons to have strong patience, being able to carefully and steadily work through a complex procedure without rushing, and persistence to overcome challenges when difficulty arises, as well as faith to continue protecting the patient's veins even in times of fatigue. And I want to show this another rupture case of the A1 aneurysm. Although what I am discussing today is how to preserve the Sylvian veins with various staging detachment techniques, it does not mean we could preserve all veins in actual surgeries. You can see that I try my best to detach the frontal bridging veins, but actually this completely broke my view to access of the aneurysm. So for our surgical goals, if the veins to be an obstacle, we need to sacrifice those veins. The quote from Sima Qian, a record of the grand historian, he said that if one should cut off but does not, chaos will follow. This implies that failing to making timely decision or making necessary actions can lead to a disorder or trouble. The Chinese character Huo means result and symbolize outcome of a consequence of an action. Another Chinese character Duan literally means to cut off or to sever. It conveys the idea of making a clear, definitive choice of actions, much like cutting off options to avoid hesitation. Together, Huoduan means decisive, describe a quality of acting with clear purpose and unwavering commitment. It means making decisions quickly and firmly, reflecting both the intent to achieve the results and solve to make a direct, unhesitating path. In neurosurgery, just now, Dr. Lucy had showed the slides, making us we should chase the perfectionism because we will have excellency. But sometimes decisiveness is essential. When vein cutting is necessary, the priority must remain to the overall surgical goal. Whether that goal is tumor removal, hemorrhage control, or revealing pressure on the critical brain area, hesitation at the critical moments can lead to suboptimal outcomes. While an overly perfectionism may compromise the success of the operations. Well, based on the previous 5 stages, I would like to add a 6th stage for a conscientious sacrifice of the veins. We must strike the balance between the vein preservation and decisive actions by prioritizing the end of the goal of the surgery. We can ensure that each step can align with the patient's best possible outcome. Well, if the veins that needs to be sacrificed is highly developed and could be potentially cause significantly venous reflux or obstruction, we should implement the 7th stage, the Sylvian vein reanastomosis, after completing the core surgical procedure to reconstruct the venous outflow pathway. I want to end with this case. This the suprasellar region tumor, and I have a quite doubt for the pathological entity. What kind of tumor is this? It looks like schwannoma, but it's not like a normal location for trigeminal schwannoma. But we have some cavernous sinus extension of this tumor. There might be oculomotor schwannoma, I guess. And we also do the transposition of the sphenoparietal sinus here, and remove the anterior reclinal process. Open the dura and split the Sylvian fissure. We can see this bridging vein have a limited our access to the surgical field. It's quite a giant tumor here. We continue to dissect the frontal basal vein and sacrifice the small branches. You can see another small branches here. We sacrifice it to have a better outcome exposure and detach the temporal branch of the Sylvian vein to have better access cordial artery here. You see the tumor kind of derived from the cavernous sinus. So I have pretty sure for this is a oculomotor schwannoma. I use stimulator to mapping the oculomotor nerve here, but it turned out to be the tumor have a completely enwrapped oculomotor nerve here. So I cannot preserve this nerve for this kind of tumor. And continue to detach the frontal basal vein, which is the remaining branches of this to have better access to the deep seated surgical field. And continue to sharp dissection to map in the oculomotor nerve. Have quite strong adhesion. This oculomotor there. This is basilar artery. Continue to sharp dissection, preserve all the small branches on the brainstem. This is a last piece of tumor. This is actual oculomotor nerve here. The supracerebral artery, the veins, and the schwannoma have a complete resection for this tumor. Well, to conclude, the preservation strategies for the Sylvian veins can be summarized as follows. The first, the concept of protecting the Sylvian must be firmly established, which like the protection of the ocular nerve, internal carotid artery, and important porphyrias. The patency of these veins is crucial to the success or failure of the surgery. The preoperative assessments such as MRV, CTV, and DSA should be conducted to evaluate the venous drainage, ensuring the Sylvian vein is protected during the surgery. On the next, depending on the specific surgical requirements, different stages of detachment techniques should be implemented. On the operation table, there must be a steadfast commitment to both the concept and techniques, with patience and meticulously in the surgery, making every effort to preserve every vessel in the subarachnoid space. Finally, all of these concepts, techniques, and phase must be serve the ultimate goal of their surgery. When conflicts arise, it is necessary to decisively sacrifice less critical veins in order to safely achieve the surgical goals. Finally, let me allow me to introduce West China Hospital, Sichuan University. Is one of the most prestigious and comprehensive hospital in China, located in Chengdu, Sichuan province. Chengdu is known as the land of abundance for 2,000 years. mostly due to the Dujiangyan irrigation system. And the West China Hospital for decades has been ranked the second best hospital of China. The neurosurgery department has been ranked the third best department of neurosurgery of China. Our department had 4 wards and 336 beds and over 100 doctors. We are divided into 11 subspecialties: the skull base, cerebrospinal vascular disease, glioma, functional surgery, stereotactic radiosurgery, and neurointervention, and radiospinal disease, pediatric, trauma, ICU, and IOM. Recent years, we have about 130,000 outpatients and about 13,000 surgeries per year. This is our family group photo. This is our skull-based center. Thank you. Thank you for your attention.
Thank you for your interesting and great and excellent presentation. Thank you, Professor. Any questions from audience?
I have just a comment, not a question, and I want to congratulate Professor Xin Zhang for his beautiful, beautiful, excellent presentation, and thank you for having shared with us. And we are very happy to see that we share the same philosophy of microneurosurgical basic technique, and this is a superb, superb demonstration of surgical skills about how to preserve veins. That is critical part in every kind of surgery, especially in skull-based surgery, and especially in all the super challenging cases that they show it to all of us. Anterior clinoid meningiomas, that is one of the most challenging pathologies in neurosurgery, posterior clinoid, and also very, very unusual case of third nerve schwannomas that I never see a third nerve schwannoma huge like that. So congratulations, and totally agree with you. Just a small, simple question. I saw and I really appreciate your very schematic approach in describe the technical step of vein preservation. And you told that you start with the main trunk and then you go toward the periphery. But what's about the order? When you have to skeletonize the vein, you start from at the center of the veins group or at the periphery and then move toward the center. So it's centrifugal or centripetal order that you follow in your mind. This is one of my personal, it depends from case to case. For example, one of the most critical part, because preservation veins is challenging everywhere, but especially in the Sylvian sphenoparietal sinus complex, it's very, as you showed us, it's very critical. So which approach you use in terms of order of steps? I don't know if my question is clear or not.
Yeah, very clear. And for the preservation, when I first start to evaluate these surgeries, if I need to do extradural clinoidectomy, which the fifth step will become complete, the transposition of the sphenoparietal sinus, I will done that, and open the dura. When we evaluated the venous type of the venous structures, and I always start from the distal end of this Sylvian vein fissure to split the frontal and temporal branches of the Sylvian veins to have a more wide corridor of the Sylvian fissure, and then depends on the structures. I will do the second stage of the detachment of the main trunk to have a better access to the deep-seated operative surgical field, and then do the third stage, which is the frontal detachment. This normally gives us wider exposure, but the superficial branching vein with the frontal Sylvian vein normally have a very short length. So sometimes we need to sacrifice those small branches to get access to the surgical field. In most of the cases, this is enough. But sometimes, if there's a different kind of tumor, for that calcified meningioma, we need to see the top of the tumor very high. So we could use the OZ approach, or we can also mobilize the temporal branch of the Sylvian vein to have a better retraction of the temporal lobe to expose the top of the tumor. And also with that very giant oculomotor schwannoma, we can also use this technique to decompress these veins. Personally, I didn't have a case of reanastomosis for the Sylvian vein, but I'm still waiting for that case. Maybe sometimes we need to, but as for recent years, I didn't encounter with that.
Yeah, it's a step forward. You know, it's 4.0, not 3.0. Yeah, okay.
Yeah.
Let's see but you can do it because you are you know, gift end. So congratulations for your beautiful technique. Congratulations.
Thank you. No, thank you, Professor Luzi.
Professor, thank you for your nice and good presentation. And I think totally. I totally agree. You're talking, but I think especially sixth and seventh stage, you know. But for the consciousness of sacrifice of pain, and we need the clear field, you know, clear in the operation. No blooding, no blood field. So, do you have some recommendation technique for the hemostasis? For example, extradural approach. We should do. We can get a very wide space with extradural approach, but sometimes any hemorrhage from the cavernous sinus, you know. So sometimes it's very exhausting. So please, do you have some techniques for that situation? Please tell me about that.
Yeah, that's I think is a very good question because our skull-based surgeons and vascular surgeons were constantly facing the bloody field of the extradural approach. I think the patient position and head position is quite crucial. We need to lower the venous drainage flow to have a lower the venous pressure. So I always level up the patient body and have a head extended to have a better outflow. And also I asked the anesthesiologist to keep the air pressure to also lower the venous flow. And also during the surgical field, we use the surgical flow to identify to achieve a hemostasis. But sometimes the surgical flow may obstruct our view. So I normally use cottonoid to compress the bleeding, and then remove the cottonoid in about 3 or 5 minutes, and then wash it out. So we have a better surgical field of this, and most of the time is this. Yeah.
Thank you. I agree that recently I use probable material in this situation, so I'm very effective. I think so. Recently I will also I use probable material. Thank you for your opinion. How about another question? Yeah. Thank you. How about another questions for the professor?
Yes, and thank you, Professor Singh, for your great presentation. And first of all, I'd like to congratulate to you and also the Washi group of in Sichuan, and really great words about the skull-based surgery. And it's indeed a fascinating lectures to learn about the techniques. And I totally agree that we need to master the techniques for the venous dissection. And I think especially for me and the other young neurosurgeons who are watching this YouTube channel and Zoom video. So I think it's very important to us to know first of all is to know the venous anatomy, and also, if possible, to study it in the cadaver, as mentioned by Professor Nusi, who emphasized on the cadaveric training for the anatomy. I think it's also important as well. And then next, to go back to your lectures and know about the classification. And I think the one you quote about the Japanese classification, and it was also discussed previously in another ACNS webinars. It's very useful to learn about that as well. And my only a small question first is about the oculomotor schwannoma. So may I ask if is the schwannoma arise within the cavernous sinus? So how would you do you encounter severe venous bleeding once you open or to debulk the tumor, and how do you control it? Or do you devascularize the tumor first? Because I think all the neurovascular structure was encased within the tumor. So how would you approach the tumor first?
Well, I personally have encountered 3 cases of oculomotor schwannoma. The two of them were kind of giant. The third is just very tiny, have a tumor apoplexy of this tumor. This I'm showing you, this is a second case. The first case I have a completely no clue. This is oculomotor schwannoma. But the second case, when I look at it, I know, here we go, it's another one, because I have a very typical MRI signal like a schwannoma, but it's not a trigeminal schwannoma, and have a cavernous sinus extension and have a supercellular extension. So it's a very typical sign of a oculomotor schwannoma. And for the cavernous sinus surgeries, sometimes we may encounter with some massive bleeding. For the transnasal surgery, I would use a surgical flow, but if it's open surgery, I tend to use just the gel foam to pack the cavernous sinus, to avoid the use the surgical flow during the cavernous surgery inside of the cavernous sinus, because I personally have a case of during the extradural dissection, I inject the surgical flow, and the surgical flow inflowed backwards inside of the Sylvian vein and blocked all the venous system. Because I opened the dura, I find out that the Sylvian vein turned kind of pale white, and most of the time, gel foam is quite useful to control the venous bleeding, because when we're using the Kawase approach, most of the time we were encountered with a superior petrous sinus. I always use a gel foam to pack inside of the sinus and coagulate it to achieve the completely and faster hemostasis for this sinus. I know some doctors like to use a titanium clip or just suture in it, but I think this way the coagulation with the gel foam is kind of efficient for control this kind of bleeding, and never inject any surgical flow for this area. This might have obstruction for the venous system. I only want the hemostasis to remain on the wound of these veins, not distally. That's my opinion. Thank you.
Thank you so much, and congratulations again. Thank you so much.
Thank you. I want to thank you so much once again before to leave, and thank you once again to Professor Kato, Professor Bing Su, Professor Ben, Professor Xin, Professor Ya, and Professor Kuti. And you have been so kind to us, and thank you for your patience. And it was to this beautiful, beautiful, meeting.
Thank you very much. I think we can wind this up. Prof. Abiko, any concluding remarks from you?
Meet the Cairo, everyone, and nice lecture, and I'm very glad and to see you see everyone in this web seminar. Sorry, I'm late because of the
Sure.
yeah.
Yeah, it's great to be here. I'm really looking forward to meeting you guys in person in the future. Thank you.
Thank you very much. So I
Great.
just update you all that this is being broadcasted on WeChat, YouTube, and Zoom. And as of now, we have around 520 people who have logged in through all different channels.
And on behalf of the Educational Committee of the ACNS and the President, Professor Kato, I would like to thank both the speakers of today, Professor Sabino Lucy and also Professor Sinsen, as well as the Chair, Professor Busa Kongu, and Professor Masaru Abiku for the time and the support for the ACNS webinar. A special thanks to Professor Sylvian for broadcasting this webinar on the WeChat channel, and special thanks to my co-host, Roger, for joining me today. So until we all meet online tomorrow in the ACNS Eastman webinar, which will be at 7 p.m. Japan time, it's a bye-bye from all of us. And thank you so much for joining.